So picture this. You're in an emergency room, trauma bay, and the difference between life and death actually comes down to two dead languages.
Which is pretty wild to think about.
Right. I mean, mixing up the Greek word for upon and the Latin word for below, it doesn't just change, a diagnosis on a chart. It completely changes the physical shape of a brain bleed.
Yeah, and the speed at which a patient crashes, plus the surgical tools you need to save them.
Exactly. So today, we are taking a deep dive into the foundational toolkit of medical vocabulary. Our mission, with the sources we've gathered, is to demystify the big three locators that basically map out the human body.
Right, the prefixes peri, epi, and subi.
Which, I have to admit, always sounded like diseases to me, but they're not.
No, not at all. They are an essential foundation for anyone trying to understand health or anatomy. These aren't intimidating suffixes that name, like complex illnesses. They are simply positional markers.
Just telling you where one structure sits relative to another.
Yeah. Exactly. Around, upon, and below. If you understand how they function, you stop seeing medical terminology as this random string of syllables you have to memorize.
And you start seeing it as a really precise three-dimensional coordinate system.
Right. It's a map.
And I always assumed medical jargon was just, a way to categorize different body parts with totally unique names. But reading through our sources, the overarching theme is that this vocabulary is highly relational.
Very much so.
So before we get into the literal life and death stakes of confusing these prefixes, we really need to map out what they actually mean, and I guess why medical students constantly stumble over them.
Yeah, the confusion usually starts because people think of these prefixes as absolute directions, like north or south on a compass.
But they aren't.
Right, they aren't. They are entirely relative to the root word that follows them. So we can break down the primary trio to see how this works. First up, we have peri, which comes from the Greek word meaning around or surrounding.
Okay, so when you see peri, you picture a continuous boundary layer, or like a ring drawn around a central structure.
The physical perimeter, yeah, exactly that. Then we have epi. This is also from Greek, meaning upon, above, or outer.
So something layered directly on top of something else?
Yes, or situated just outside another structure. It strongly implies surface contact. And finally, sub, which is derived from Latin, meaning under or below.
Okay, so a position beneath or deeper than your reference point, basically one layer down.
You got it.
So peri is around, epi is upon, and sub is below. I mean, on paper, that sounds incredibly straightforward.
It does, until you realize the human body isn't a flat plane.
Right. It is a nested stack of membranes and tissues. You've got skin, fascia, periosteum, dura mater, arachnoid mater, pia mater, pleura, peritoneum. It's an anatomical onion.
That's a perfect way to put it. And that layered reality creates what we can call the relativity trap. A specific membrane can be simultaneously epi to the layer beneath it and sub to the layer above it.
Wow, okay.
Yeah. The prefix only has meaning when it's anchored to a specific reference point. If you change the root word, you alter the entire map.
I think of it like going outside in the dead of winter. Like, you might wear a t-shirt, a heavy wool sweater, and a thick winter parka.
Right.
So your sweater is sub to your parka, it's underneath it. But that exact same sweater is epi to your t-shirt because it's sitting directly upon it.
Yeah.
The sweater didn't move at all. Your reference point did.
That visual captures the logic perfectly. And because doctors need absolute precision when navigating these layers, they have a few other terms in the neighborhood that we should probably distinguish.
Oh, like supra and infra.
Exactly. If sub means below a layer, we have to account for those two as well.
I've always wondered about the overlap there, actually. Like, if sub and infra both mean below, why do we need two totally different prefixes?
It comes down to distinguishing between a layer and a landmark. Supra is Latin for above, and it's the standard vertical opposite of sub. For instance, suprapubic means vertically higher than the pubic bone.
Okay, so supra and epi both roughly mean above, but
supra implies a position higher up on the vertical y-axis of the body, whereas epi implies direct physical surface contact.
Got it. And what about infra?
Infra overlaps with sub, sure. But in clinical practice, infra is typically used for a position vertically below a landmark, like inforbital, meaning below the eye socket.
While sub is reserved for being physically buried beneath a covering layer.
Right, like subcutaneous fat under the skin.
That makes a lot of sense.
Yeah.
And with peri meaning around, our sources note a frequent mix-up with the prefixes inter and para.
Oh, definitely. The distinction there is adjacency versus encirclement. Inter means between, as in the intercostal muscles that sit between your ribs.
Right.
Para means beside or near. If you're parked para to a fire hydrant, your car is just beside it.
But if you're parked Peri to that fire hydrant, you have somehow driven your vehicle in a continuous loop completely surrounding it.
Exactly. It's a very different ticket from parking enforcement.
I appreciate that clarity. So if we take this relative coordinate system especially, the really critical difference between upon and below, and apply it to a real-world scenario, we end up back in the trauma bay.
We do.
Let's talk about brain bleeds. Because the stakes of mixing up epi and sub here are just catastrophic.
They are. To understand the physics of a brain bleed, you really have to understand the packaging of the brain itself. The brain doesn't just, float loosely in the skull.
Right, it's wrapped up.
Tightly wrapped in 3 distinct meningeal layers. The outermost layer, which is anchored to the skull, is the dura mater. That's Latin for tough mother. It is incredibly thick and fibrous.
And just inside that is the arachnoid mater, right?
Yeah.
Named because it looks like a delicate spider web.
Yes, and hugging the actual grooves of the brain tissue itself is the incredibly thin pia mater, the tender mother.
Okay, so the dura mater is where the prefixes really come into play for 2 extremely serious conditions, the epidural hematoma and the subdural hematoma. An epidural hematoma is bleeding epi to the dura. So it's happening upon or outside that tough outer membrane. It forces its way between the dura and the skull bone.
Right.
But a subdural hematoma is bleeding sub to the dura. It happens beneath the dura mater, filling that space between the tough layer and the web-like arachnoid layer.
And that specific location dictates the source of the blood, which in turn dictates the speed of the emergency.
How so?
Well, an epidural hematoma is typically caused by a high-impact trauma, like a really severe skull fracture. The fractured bone shears a major artery, often the middle meningeal artery.
And arteries are high pressure.
Very high pressure. They pump blood straight from the heart, so an epidural bleed accumulates incredibly fast. The patient might seem totally fine for a few minutes. That's known as a lucid interval.
Oh, wow.
Yeah, but then they rapidly lose consciousness as the expanding blood compresses the brain.
But the subdural hematoma is fundamentally different just because of its depth. The sources indicate this is usually a venous bleed.
Yes, it involves the tearing of bridging veins that cross from the surface of the brain into the dura.
And this often happens from a much lower impact fall, right?
Okay.
Especially in elderly patients or people on blood thinners.
That's the classic presentation. As we age, the brain naturally shrinks a little bit, which pulls those bridging veins taut. It makes them highly vulnerable to carrying.
And because veins carry low-pressure blood, this bleed just oozes. It accumulates really slowly.
So slowly that a chronic subdural hematoma might not show symptoms for days or even weeks.
Wait, really? Weeks?
Easily. It can present as mild confusion or a slight personality change in an older patient who barely even remembers bumping their head.
That's terrifying.
It is. It's one of the most notoriously missed diagnoses in outpatient medicine, whereas an epidural hematoma is a sirens blaring immediate surgical emergency.
Okay, wait. So when an ER doctor orders a CT scan, can they actually tell whether it's an arterial or venous bleed just by looking at the shape of the blood pooling in the head?
They absolutely can.
Because the scans for these 2 hematomas look entirely different, even though they're happening mere millimeters apart on opposite sides of the exact same membrane.
It all comes back to the anatomy dictating the physics. The dura mater isn't just a loose bag inside your skull. It is tightly tethered to the bone at the skull's seams.
The suture lines.
Right, the suture lines.
Kind of like the heavy stitching holding the leather plates of a baseball together.
That's a great way to visualize it. So if you have an epidural bleed, high-pressure arterial blood pushing between the bone and the dura, that fluid forces the dura away from the skull.
But then it hits the stitching.
Exactly. When the expanding pool of blood hits those rigid suture lines, it hits a wall. The dura is anchored way too tightly there.
So it can't spread out.
Right. Unable to spread laterally, that high-pressure blood is forced to bulge inward, pressing directly into the brain tissue.
And on a CT scan, this creates a very distinct biconvex lens shape.
Yes, an epidural bleed cannot cross a suture line.
The tethering creates a dam. But because a subdural bleed happens beneath that tough layer down in the web-like arachnoid space, it faces absolutely none of those restrictions.
None at all. There are no rigid seams anchoring the tissue down there.
So the low-pressure venous blood just oozes freely, spreading out widely over the curve of the brain.
Which creates a long, thin crescent shape on the scan. It easily crosses the skull's suture lines, because it is entirely unconstrained by the dura's attachment points to the bone.
That structural logic is just brilliant. The word tells you the location explains the mechanics, and the mechanics produce the shape on the screen.
It really is an elegant system.
But these prefixes dictate way more than just trauma surgery. They are the underlying instruction manual for how millions of people manage their daily health.
Oh, definitely.
I mean, the prefix sub is everywhere in pharmacology and drug delivery.
It's the defining feature of sublingual administration. Sub meaning under, lingual meaning tongue.
Which is the required delivery method for medications like nitroglycerin for sudden chest pain, or buprenorphine, widely known as Suboxone, used in treating opioid use disorder.
Right.
And I really want to highlight the mechanics here, because understanding why we bypass the stomach is a massive aha moment for a lot of people.
It really is.
If you swallow a traditional pill, it faces a total gauntlet. It has to survive the highly acidic environment of the stomach, pass into the intestines, get absorbed into the blood, and then make a first pass through the liver via the portal vein.
And the liver's primary job is to filter toxins. So it heavily metabolizes and destroys a large percentage of that drug before it ever reaches your general circulation.
That process is called first pass metabolism, right?
Yep. And it's exactly why oral doses of medication are often much higher than intravenous doses. You lose a lot of it.
But the tissue sublingually directly under the tongue is incredibly thin and densely packed with capillaries.
So when a drug is formulated to dissolve there, it diffuses through that thin membrane and enters the venous system directly. It completely bypasses the stomach acid.
And crucially, it skips that first pass through the liver. The active medication dumps straight into the systemic bloodstream in a matter of minutes.
It's kind of like a biological bypass lane, honestly.
We see that same targeted precision with subcutaneous injections, too. Millions of patients self-administer medications every single week, from insulin to the massive new wave of GLP-1 receptor agonists for diabetes and weight management.
Drugs like Ozempic, Wegovy, Mounjaro, Zepbound.
Exactly, and the directions mandate is subcutaneous injection.
Sub meaning under, cutaneous meaning skin. The goal is to deposit the medication into the adipose tissue.
Which is the fatty layer situated beneath the epidermis and dermis, but above the muscle.
Right, and the reason for this specific depth is all about absorption speed. Muscle tissue has a massive blood supply, so a drug injected there acts very quickly.
But adipose tissue has a much poorer blood supply.
Exactly. Injecting a drug subcutaneously ensures a slow, steady, sustained release of the medication into the bloodstream over hours or days.
Which is exactly what you want for a baseline insulin or a weekly GLP-1 dose.
Yes, they are putting the medicine exactly where the word dictates to manipulate the speed of absorption.
Now, the prefix Peri also had a massive moment in the public spotlight recently, far outside clinical circles.
It did, specifically regarding the pericardium. Peri meaning around, cardium meaning heart.
The heart is this heavily working muscle, beating roughly 100,000 times a day. To prevent it from experiencing massive friction against your lungs and chest cavity, it sits inside a double-walled, fluid-filled sac.
The pericardium.
Right. And when that lubricating sac becomes inflamed, often due to a viral infection or an autoimmune response, the condition is called pericarditis.
Which became a household term during the COVID-19 pandemic and the rollout of mRNA vaccines.
Because public health regulators were tracking a rare but notable safety signal in young males following vaccination.
Yes. The data showed elevated rates of myocarditis, which is inflammation of the actual heart muscle, the myocardium, and pericarditis, inflammation of the surrounding sac.
Suddenly, public discourse was completely immersed in the nuances of anatomical prefixes.
Yeah.
People were trying to distinguish the clinical severity of an inflamed muscle versus an inflamed boundary layer.
It was fascinating to see those terms used so widely.
Speaking of public terminology, I noticed a really interesting discrepancy in our sources regarding pain management during childbirth.
Oh, right.
In the U.S., expectant mothers receive an epidural block. But older texts and extensive medical literature from Europe and South America refer to it as a peridural.
I see where you're going with this.
How do those two prefixes describe the exact same procedure?
They describe the same physical space, just from slightly different linguistic perspectives.
Yeah.
The medication is injected into the space outside the dura mater of the spinal cord. You can technically describe that space as epi, meaning sitting upon the dura, or peri, meaning surrounding the dura. English language clinical convention just settled on epidural decades ago. But peridural remains standard in many Romance languages. It's a phenomenon called terminological drift.
proving that even highly rigid scientific fields are not immune to regional dialects.
Definitely not.
That collision of language leads directly into the misconceptions scattered throughout medical history. We have this blend of Greek and Latin heavily influencing modern medicine, and it's created some really fascinating blind spots.
Yes, like the assumption that sub always describes a physical location.
That is a wildly widespread misconception, because sub frequently functions as a degree modifier, meaning less than, partial, or below a certain threshold.
Right. If a doctor describes an illness as subacute, they don't mean it's physically underneath anything.
They mean the disease process is moving slower than an acute illness, but faster than a chronic one.
Exactly.
The one that always catches me is subclinical. You might have subclinical hypothyroidism. Your lab results show your thyroid hormone levels are slightly off, but the disease hasn't reached the threshold to produce detectable physical symptoms. You feel fine.
It's beneath the clinical horizon.
Exactly. And in a surgical context, a subtotal thyroidectomy means the surgeon removed most, but not entirely all, of the thyroid gland. The prefix is indicating a failure to meet a 100% threshold.
That's spot on.
Here's another misconception that honestly blew my mind in the research. The epidermis is widely taught as the outer skin because people just assume epi translates to outer.
It's a logical guess, for sure, but factually incorrect. Epi translates to upon. The epidermis is named solely because it is the tissue sitting upon the dermis.
The fact that it happens to interface with the outside air is purely circumstantial.
Yes, entirely.
Which completely explains the epithelium. The epithelial tissue lines your gut, your respiratory tract, your blood vessels.
It's deep inside your body.
Nowhere near the outer environment. It is called the epithelium because it sits upon deeper layers of connective tissue. It obeys the positional rule, not the environmental one.
Exactly. We also need to revisit the Peri and Peri confusion because it creates huge anatomical misunderstandings.
Like with the parathyroid glands?
Yes. So the parathyroid glands are 4 tiny nodes that control calcium levels in your blood. They sit on the back of the thyroid gland. They are para, beside, or near the thyroid.
But if they were parathyroid glands, they would have to wrap entirely around the thyroid like a tight collar.
Which they don't.
But the absolute peak of this linguistic confusion is the great adrenaline versus epinephrine debate.
Oh, this is a classic.
For years, I genuinely thought these were two slightly different medications. Like maybe one was used for different types of allergic reactions and one was for cardiac events.
A lot of people think that. It's arguably the most famous quirk in medical terminology.
Yeah.
Adrenaline and epinephrine are the exact same chemical compound.
Literally the exact same.
Yes, they're the exact same hormone secreted from the exact same gland, triggering the exact same fight-or-flight response in your sympathetic nervous system.
I don't understand how modern medicine ended up with two entirely different names for the exact same molecule.
To solve the mystery, you just have to look at where the gland sits in the body. It rests like a little cap right on top of the kidney.
Okay.
If you are a 19th century scientist naming this gland using Latin roots, the prefix for near or toward is ad, and the word for kidney is renal. You merge them, and you get the adrenal gland.
Which secretes adrenaline.
Exactly.
But if a different scientist decides to use Greek roots, the prefix for upon is epi, and the Greek word for kidney is nephros.
Merge them together, and you get epinephrine. They literally both translate to the stuff that comes from the thing on top of the kidney in 2 completely different ancient languages.
That is wild.
Isn't it? American pharmacology and literature heavily adopted the Greek convention, standardizing on epinephrine. British medical literature and much of European usage maintained the Latin tradition and kept adrenaline.
It's astounding that such a critical life-saving drug had an identity crisis just because of classical translation. But that raises a bigger question, I think.
What's that?
How did we end up with this rigid, hybridized system of Greek and Latin in the first place?
Honestly, by inheriting a sprawling, unorganized mess.
Oh, really?
Yeah. Physicians had been combining these prefixes with root words since Hippocrates in ancient Greece around 400 BC.
Wow, that long ago.
Yes, and centuries later, in the 2nd century CE, the physician Galen wrote massive treatises that effectively locked in the Greek anatomical vocabulary.
Right.
When Latin-speaking anatomists in the Roman Empire and the Renaissance began dissecting and documenting the body, they absorbed Galen's Greek terms while adding their own Latin words.
But there was no central governing body checking our work, was there?
None. Zero. By the late 19th century, anatomical terminology was in a state of absolute chaos. Depending on which university you attended or which textbook you bought, A single ligament or artery could have up to 5 different Latin, Greek, or localized vernacular names.
So a German surgeon could barely decipher a French anatomist's notes.
Not without extreme ambiguity. And the precision required for modern surgery was basically impossible under those conditions.
So the medical community had to force standardization. Our sources highlight the 1895 Basel Nomina Anatomica, or BNA, produced by the German Anatomical Society. That was the first global attempt to purge the duplicates and create one official list.
It was a monumental effort. The BNA was later revised at a conference in Jena in 1935 and then overhauled again in Paris in 1955 to create the Nomina Anatomica.
But the system we rely on today is the Terminologia Anatomica, established in 1998, right?
That's correct. By the Federative Committee on Anatomical Terminology, it dictates a globally approved, standardized list of roughly 7,500 anatomical terms.
And that is exactly why peri, epi, and sub are inescapable today. They were legally locked into the approved vocabulary that every medical school, textbook, and regulatory agency on Earth is now required to use.
It cured the 19th century chaos, for sure.
But it seems like that standardization also created a false sense of finality. Like, the vocabulary might be fixed, but our biological understanding of the tissue it describes is still evolving.
That's a really crucial point. Assuming anatomy is finished is a dangerous trap. And the best recent example of this involves a structure called the mesentery.
Oh, the mesentery is such a fascinating story. The word comes from peri, attached to the Greek word tehenos, roughly meaning the stretched membrane around the intestines.
Right. And for over a century, traditional medical education taught that the mesentery was a highly fragmented, disconnected series of tissues.
It was classified as a mere peri structure, just a membrane defined entirely by the loops of intestine it's surrounded and suspended in the abdomen.
It was viewed largely as biological packing material, literally just stuff taking up space.
But starting around 2012, a surgeon named J. Calvin Coffey at the University of Limerick began conducting extensive microscopic and structural studies of the abdomen.
And he discovered that a century of textbook diagrams were fundamentally incorrect.
Completely wrong.
The mesentery was not fragmented at all. It was one contiguous, highly complex structure with its own massive vascular and lymphatic network.
He realized that treating it as just an empty boundary layer was blinding surgeons to its actual biological function.
So in 2016, Coffey published his peer-reviewed findings in the Lancet Gastroenterology and Hepatology. He formally proposed that the mesentery be reclassified from a simple membrane into a distinct, standalone organ.
And the medical establishment agreed. Major institutions and textbooks, including the legendary Gray's Anatomy, updated their classifications.
It sparked a profound philosophical debate in the surgical world. Can a peri structure, something linguistically defined only by its relationship to other organs, be promoted to an organ itself?
Coffey proved that our linguistic labels had actively suppressed our scientific curiosity.
He really did. And understanding the exact shape of these membranes has massive historical weight, too. Consider peritonitis, the inflammation of the peritoneum.
Which is the massive membrane lining the entire abdominal cavity.
Right. Before the discovery of modern antibiotics like sulfonamides in the 1930s and penicillin in the 1940s, a ruptured appendix that triggered peritonitis was largely a death sentence.
Because the peritoneum is one continuous structure.
Yes. Bacteria entering that space had a superhighway to infect the entire abdomen, with absolutely no internal walls to contain the sepsis.
That historical reality perfectly illustrates why understanding these spatial relationships is non-negotiable. These aren't just empty spaces or thin wrappers.
Not at all. The continuity of a perilayer, or the depth of a subspace, dictates exactly how a bacterial infection will spread, how a metastatic cancer will migrate, and how a surgeon must navigate to remove it safely.
Let's pull all of this together for a final review of the map for everyone. Peri means around, describing a perimeter or boundary layer.
Epi means upon or outside, sitting directly on the surface.
Sub means under or beneath. But the golden rule of this entire system is relativity. Because the body is a nested stack of tissues, these prefixes only have meaning in relation to the root word they modify.
Right. Relativity is everything. We saw the clinical weight of that in the skull.
Yeah.
An epidural bleed is arterial, high pressure, and lens-shaped because it is physically trapped outside the dura mater by the skull's suture lines.
While a subdural bleed is venous, low pressure, and crescent-shaped because it oozes freely in the unconstrained space beneath the dura.
We also tracked subin into the world of drug delivery. We explored how sublingual medications bypass the liver's first-pass metabolism.
And how subcutaneous injections utilize fat tissue for slow absorption. We cleared up the linguistic chaos of adrenaline and epinephrine, realizing they're just Latin and Greek translations of on the kidney.
And we learned that this highly rigid terminology system was a deliberate century-long invention designed to cure the ambiguity of 19th century medicine.
It is a remarkable system of logic. Once you grasp the spatial rules, you possess a skeleton key that unlocks thousands of clinical terms.
Absolutely.
Which brings me to a final thought for you to consider long after we wrap up this deep dive. If Surgeon J. Calvin Coffey was able to analyze the mesentery, a tissue linguistically dismissed as a mere peristructure, and upgrade it into a fully recognized standalone organ,
It really makes you wonder about the rest of the map.
exactly what other mere layers, boundary membranes, or empty spaces in the human body are out there right now? Spaces currently ignored by science because of their humble prefixes that are actually entirely undiscovered organs just waiting for the right anatomist to look a little closer.